Next topic is brachytherapy. So like I said, this is delivery of radiation from the inside of the prostate. The most common type is low dose rate. A lot of folks simply call them seeds. And a lesser performed type, but my particular preference is high dose rate, and I'll talk about both of those. So the rationale for brachytherapy is that you can deliver doses from the inside of the prostate that are much higher than if you were delivering from the outside, because the radiation doesn't travel far, and it doesn't have to travel through other tissues and avoid bladder, rectum, and hips. So we can get more dose there. There's been some studies that have looked at doing biopsies after radiation therapy. So if you just look at some old doses of radiation from decades ago, even after a full course of radiation, you can biopsy that patient and still see some active cancer cells 40% of the time. It doesn't mean that their PSA is going to come back, but it does correlate with that at some point. Adding hormone therapy decreases that by about half. So using hormone therapy plus radiation, it acts to sensitize those tumor cells to the radiation, so they're more likely to die. More modern radiation with modern techniques where we can use a higher dose, we only see positive biopsies 15% of the time. And then with brachytherapy, this is from a series using seeds, it's a very low rate of positive biopsies. It's also the most conformal form of radiation. So conformal is a term that we use a lot, meaning how tight is the dose packed into the target. So I showed you pictures like this earlier. This is photons, even with our best planning. You see some of this low intermediate dose kind of spilling out around there. Most of those tissues are pretty tough. The rectum is our most sensitive target there. Bone is minimal. But we never like radiating anything that we don't have to. This is a proton plan. And protons are just another form of external radiation therapy. But the way that the plans are delivered is some centers will break it up a right and left each day. Our colleagues in Warrenville do a left lateral beam on Monday, then we'll do a right lateral beam on Tuesday and just alternate back and forth. But the cumulative dose looks like this. And as you treat the whole prostate, you come a little more superior. The bladder still sees some radiation. The rectum still sees some radiation there. But with brachytherapy, with all the radiation inside of the target, we can really eliminate all of that radiation that's in the surrounding tissues there. Just logistically, the treatments are shorter. So with seeds, it's usually one planning session and then a one-time implant. With the high dose rate that I'll talk to you about, we do it in 2 sessions. And this is versus 39 or so sessions for the external radiation. And it's also cost effective. If you look at how much an open prostatectomy costs versus a robotic versus the external radiation with IMRT and protons, with all of those different options, brachytherapy always comes in, usually at about half of the cost of all the others. So if cost is an issue for a healthcare system, then brachytherapy is a really good option. So patient selection, in general, up top, these are kind of selections just for treatment in general, kind of comparing to active surveillance. For brachytherapy in particular, and this is more related to prostate seeds, the things that we look for is if they had a previous TURP, which is pretty uncommon. If they had a small TURP, then we can still do the implant. But if it's large, then that's difficult. And then how big the gland is. So a big gland means that you're going to have more bony interference when you're trying to place those needles. The pubic arch gets in the way. And then the patients have to have reasonable urinary function before the implant. If they have really poor urinary function before you do it, and then you stab the prostate with 20-something needles, they're more likely to go into urinary retention or have long-term urinary issues. But usually if the guys have good urinary function going in, it's good coming out. So we'll talk about these two types of brachytherapy procedures. I kept this in here mostly for reference in case you guys go back to the slides later on. But these are the most common types of seeds that you'll see: iodine, palladium, and cesium. The main difference is how long they last, how long it takes to deposit the radiation. So this delivers half the dose in 60 days. Palladium is 17 days. Cesium is just under 10 days. So kind of worse side effects initially, but quicker to get better. Better side effects initially, but it takes longer for those to get better. So with prostate seeds, this is the workflow. The patient will come in and I'll do a transrectal ultrasound. So the patient will be in the dorsal lithotomy position, so on his back with legs up, not on the side like a lot of biopsies are done. And I'll be taking pictures starting at the base and then coming through the prostate down to the apex, drawing out the volume of the prostate and looking at the pubic arch. Makes this little kind of upside down V here. You can't see it on this picture. The pubic arch is a couple slices more inferior. But what I'm looking for is, okay, and there's a grid here. Those are going to correspond to our needles. Up here, I can see where the prostate is widest. Am I going to get blocked there or there by the pubic bones? So that's kind of the assessment of the anatomy that we're doing. So we have these pictures that go from superior to inferior, anterior to posterior, right to left, and we'll come up with a plan in order to cover the whole radiation or the whole target. And so I'll get reports that then look like this. And this is the grid that we're following for the implant. So this grid actually gets placed up against the patient's perineum, and then we're introducing needles according to this coordinate system, using the ultrasound to make sure that it's in the right spot. So the ultrasound will show this grid again, and we can make sure that it correlates there with where we're intending on our plan. Then each of these needles, so that'll be needle 1, corresponds to that needle there. And I can see that there's, green means that there's a seed there. So there's 5 seeds in that needle. And it'll go all the way up to the base of the prostate. The next row, needles 3 and 4, will just be a ½ centimeter off of the base. So in 3 dimensions, it spaces those seeds out as best as possible. And the procedure just proceeds until we get all needles in, and then verify with the ultrasound that we like the position, and then drop them off. And here's a view of what it looks like in the operating room. So we have the transrectal ultrasound. This is all rigid, so it's fixed to the OR table. The template, so that's the grid up against the patient's perineum. And then we can just click the probe in and out, so we see various levels of the prostate. Drop off all of the seeds when we're happy with the positioning, and that's what you'd get on an intra-op x-ray. And then the patient comes back 30 days later. We do a CAT scan so we can find all of those seeds and actually calculate the dose that the patient got. It's not uncommon to see a really nice looking implant at the time, and then 30 days later those seeds have moved some. So it's a phenomenon called seed migration, and that happens a fair amount. The procedure ends with a cysto in case there's any seeds that were dropped off in the bladder or the urethra. So that way we can retrieve them in the OR rather than having the patient urinate one out afterwards. With this procedure, the patient, we have them strain their urine at home for about a week. And the bigger precaution is a 2-month restriction on being close to anybody under 18 or a pregnant woman because the patient's radioactive. Now, in all actuality, these seeds are such low energy that it doesn't travel outside the body to any meaningful level, but it's just over precautious that you would hate to have Junior 50 years later get some bizarre cancer and say, oh, I sat on grandpa's lap a week after the seeds. But that's a big factor for patients who care for their grandkids or babysit, whatever. So the second type of radiation is called high dose, or brachytherapy, high dose rate brachytherapy. It's not new. It's been going on or centers have been doing it for several decades, and it has evolved over the years. It has the advantages of the seeds in that you can treat from the inside out, but it allows you to customize the radiation like we can from the external versus placing a seed and it's there. You can't do anything about it if it moves or migrates, anything like that. So instead of the larger grid, we have a freehand, a small kind of prostate-shaped grid that'll go abut the patient's perineum. We'll then place needles through these holes to fully cover the prostate. And then this is the view following the procedure. But there's no seeds here, so those needles are empty. We'll then wake the patient up, do a CAT scan, and here you can see a picture of all of those needles in place, and then work on the computer just like we do with the external radiation to draw out the bladder, the rectum. In this case, we can do the urethra because there's a catheter in, and we can shape how the radiation is going to be delivered in that respect. Once the treatment is done, or the plan is done and approved, the patient gets connected. All of those needles, usually on average about 18, gets connected to this radiation machine. So this is called an afterloader. Inside of that machine is one really strong source of radiation. The isotope is iridium-192. So it's a really powerful source. We change that about every 3 to 4 months. It loses half of its strength every 74 days. So just to keep a timely treatment for the patients, we have to swap out the sources regularly. So each one of these needles is then connected to this machine. So needle 1 from this plan will be connected, or represents needle 1 here, and will be connected to channel 1 there. So for the delivery of the plan, that seed is on a cable that's wound up in this machine. It comes out through needle 1, travels up here into the patient, and sits at the top, then takes a step back until it's treated, the base through the apex. In needle 1, the seed comes back, and then internally it rotates and then comes out through channel 2 and does the same thing. And that is repeated. Comes back, dial turns, needle 3, etc. for the entire treatment plan. So it allows us to customize the actual treatment that the patient gets on that day quite a bit more. And then this was a slide that I borrowed, but this was one of our cases that we did just a few weeks ago. Relatively large prostate, but these are just the needles that are placed. Got the urethra contoured out, and this is the actual dose that we delivered. So there's very little dose getting to the rectum. You can actually see some of these lines. There's a purple line, I believe, that kind of comes down and around. It lets us scoop the high dose of radiation off of the urethra. So that's some customization of treatment that we get with the high dose rate that we don't have with seeds, and I think is really nice. So over time, from the early 80s to present, the trend has been moving towards fewer and fewer treatments. So the regimen that we've been doing is 13.5 gray. So we do 2 implants. The patient gets that done, and then 1 to 2 weeks later has the identical treatment or the identical procedure performed again. Nothing left behind. So the patient gets their treatment, goes home that same day, returns, we repeat it 1 to 2 weeks later. So it's, I've had quite a few patients show interest because they don't want to worry about their grandkids or whatever. It is the side effects as well, because the treatment is delivered quickly. The whole treatment's about 20 to 30 minutes. The side effects are quicker to come on. They're also much quicker to go away. The intensity tends to be a little bit worse than the seeds. So the peak is, I had a couple of days where it was hard for me to pee, had quite a bit of burning. I've literally gotten a call from a patient on a Thursday. He said, I'm having a ton of burning. So I ordered a UA, it was normal. Saw him at work the next day because he works at our institution. Oh, I'm doing much better today, doc. The seeds is more prolonged, where it's not uncommon for 6 months later, you still see guys that are having some issues. So we put everybody on Flomax. Tamsulosin, sorry, I'm not paid by them. Cipro, naproxen, and then I'll give them Norco. Very few patients need it, either with the seeds or with this. Never used prednisone. Some guys I've kept on naproxen a little bit longer if they're having issues, or have escalated to the tamsulosin twice a day, but haven't had to use steroids. So the only incontinence we see is if it correlates with urgency. So if they have urgent continence that just goes along with their irritative symptoms, then guys can lose a few drops as they're getting to the bathroom. Stress incontinence just doesn't happen. The rates are less than 1%. That's reported. So it's a different type of urinary symptoms than the surgical patients. So patients under general anesthesia. Usually it's just with an LMA. I've done a couple cases under spinal anesthesia if the patient has some contraindication to general. But general anesthesia for about an hour. In this case, while the patient is waiting for us to do the planning, we can give them fentanyl or Dilaudid, usually at pretty modest doses, and they do well. It's pretty common while I'm waiting, if I go check in on the patient, he's sleeping, even with the needles coming out. And then here's a kind of comparison chart, mostly for you guys to reference later if you like, kind of pros and cons with each treatment. The seeds in general, I mean, the pros to the seeds is it's cheaper, it's less labor intensive for the doctor, but also for the patient because it's one implant in addition to the planning session. But in terms of being able to control the dose that's delivered in that respect, those aspects all favor the high dose rate. And in our experience, the toxicity has been more manageable. Again, a few days that are worse, but in general, it resolves pretty quickly.